Welcome to Inside Tract from ABGH, the Association of Black Gastroenterologists and Hepatologists. My name is Dr. Ugo Iroku, a co-founder of ABGH and a board-certified New York City gastroenterologist. It is my pleasure to welcome you to this segment of ABGH's programming for Crohn's and Colitis Awareness Week. The first week of December, where worldwide we highlight awareness of IBD and raise funds for IBD programming and research. This evening, our topic is navigating your IBD care with a team approach. I am thrilled, the word is thrilled, to introduce you to this all-star panel we've assembled today. First up, we have Tamar Samuels, registered dietitian nutritionist, co-founder and vice president of Kalina Health. Tamar, welcome to the program.
Hi, Dr. Iroku. Thank you so much for having me.
Next up, we have Alvin F. Wells, MD, PhD, director of rheumatology for Aurora Healthcare. Dr. Wells, welcome to the show.
Thank you, Dr. Iroku. Glad to be here.
And last but never the least, we have the Dr. Ryan Turner, owner of Turner Dermatology, New York City, New York, and who I went to med school with many more years than either of us will ever confess. Welcome to the show, Dr. Turner.
Thank you so much, Dr. Iroku. Thanks for having me and good to be reunited.
Same here. Let's get into it. So we know there are over 3 million patients who have IBD in this country. That includes Crohn's disease and ulcerative colitis. And one of the fastest growing demographics in IBD is the African American community. If you look at that 1970 to 2010 period, IBD grew by 40% in non-Hispanic white communities, but by 130% in the African American community. And with that growth comes new conversations about a new disease to many Black families. Now, the first principle of IBD treatment is you deserve great care. Today, we will introduce you to some of the different specialists you should expect to connect to if necessary. Let's start with you, Dr. Turner. Tell us about dermatology and what made you choose this field.
Absolutely. Well, in dermatology, we think of ourselves as the skin experts, focusing on the skin, the adjacent mucosa, as well as the hair and nails. I was inspired to do dermatology because of mentors that I came across in my medical training. I had a primary interest in oncology and then realized I had a passion towards skin cancer, and then realized that there was a huge breadth in dermatology, including procedural dermatology, getting further into infectious disease field, and so on. So I came away very much loving it because I could do a little bit of everything.
Great. Now, Tamara, what about you? Who is a registered dietitian? What made you choose this field?
Yeah, I actually, like many people, didn't know what a registered dietitian was until I met one. Registered dietitians are credentialed healthcare professionals that specialize in evidence-based nutrition for health promotion, disease management, and that can really range from just basic healthy eating to managing more complex conditions like IBD. I decided to become a registered dietitian for two big reasons. The first, I initially wanted to be a therapist, and I started working with children in Harlem. And in that program, I really saw the health disparities, particularly around nutrition and the lack of access to healthy foods. So I became really passionate about food as medicine. And then I actually struggled with my own GI condition, which my nutrition had a huge impact on. And so I got really into gut health and nutrition care for gastrointestinal conditions.
Fascinating. Dr. Wells, what about you? Rheumatologist. We may not be able to spell it, but we can understand it if you explain it. What is a rheumatologist and what made you decide to choose the field?
You know, Dr. Iroku, you're not alone. My mom even asked me, what is a rheumatologist, But we're essentially the joint doctors. We treat diseases of the muscle, bones, and joints, and what we also call a group of diseases, connective tissue disease. That could be the eyes, that could be the gut, and that's where they overlap. My interest came because of growing up in South Carolina. I remember my granddad died when he was 86 years old, had made his own cane, was using mud to treat his joints. I went off to gone to graduate school, actually, and one of my professors asked me to work on a project to set up a museum using some bones and joints. And that led me to doing all the research and looking into rheumatology. And fast forward, got my PhD in immunology, did research in arthritis, and went back to medical school and focused on rheumatology. It's exciting to be in the space and be able to offer some of the things we have for all of our patients with joint disease.
Excellent, excellent. So hopefully, if you are tuning in tonight, if you have IBD, if you're a caregiver of someone with IBD, you recognize that these are passionate people, a passionate collection of providers, just as dedicated to your care as your gastroenterologist is. I have a surprise for you today. Inflammatory bowel disease is not just a bowel disease. About 50% of patients with IBD will at some point in their life develop what we call an extraintestinal manifestation. That is a manifestation of the IBD outside of the gut. And about 25% of the time, that'll actually happen before you get diagnosed with IBD, and 75% of the time, it'll happen afterwards. And it doesn't happen just a few months in. On average, it can happen 8 years into disease. So there's really no fixing what IBD can look like. That can evolve over time. So Dr. Turner, let's turn to you. What are some of the skin changes that some of our IBD patients should even look out for? And then my follow-up question after that is, how do you treat those?
Absolutely. So one of the more common manifestations we see in inflammatory bowel disease is erythema nodosum. This typically presents on the lower extremities and classically is a nodule or an indurated plaque that's somewhat tender. In a more fair-skinned individual, it's bright red erythema, but in a more melanated patient, it can present more of a purplish or violaceous hue. Oftentimes can even appear hyperpigmented. So it's important to be able to appreciate and distinguish that in the different skin types. Erythema nodosum is an inflammatory process. It's a panniculitis, so it's an inflammation around the fat cells of the lower extremities. When you start to see these indurated plaques or nodules track above the knees, it's also important, however, to entertain a diagnosis of infections such as mycobacteria, because it's very rare for erythema nodosum to track above the knees. Erythema nodosum can be treated with intralesional steroids. It can also be treated with some topical steroids, non-steroidals like simple ibuprofen. A lot of them will clear, of course, when their inflammatory bowel disease is treated as well. In addition to erythema nodosum, one of the more common things that we see is pyoderma gangrenosum. This is often associated with ulcerative colitis, and this is one of the more worrisome skin manifestations in inflammatory bowel disease because it really does affect quality of life. Pyoderma gangrenosum is what we call a neutrophilic dermatosis. This means that it's characterized by a lot of neutrophils that are infiltrating into the skin, and they cause a rapid ulceration. Pyoderma gangrenosum is often treated first with high-dose steroids as well as intralesional steroids, and then we will transition to things like dapsone, Cellcept, and potentially cyclosporin for long-term management, and of course those things that treat their inflammatory bowel disease, such as infliximab, will also help to rapidly involute pyoderma gangrenosum. I also think wound care is important as well. So dressings that help wick away fluid, and also those such as silver impregnated dressings can be used to help prevent infection. One other thing that I'd like to mention is also hidradenitis suppurativa. This is an inflammatory condition, often of the sweat glands, but it can actually mimic and vice versa cutaneous Crohn's or metastatic Crohn's. And in fact, I had a patient at the hospital. I am an assistant professor at Albert Einstein University and also attend at Montefiore Hospital. We had a young African-American patient who had been treated for years for hidradenitis suppurativa, and then dermatology was consulted, performed a skin biopsy, discovered granulomas that could be consistent with Crohn's disease, and we then referred to a gastroenterologist. It was discovered the patient did indeed have Crohn's disease and was able to be appropriately treated.
Fascinating, Dr. Turner. Thank you for that. And so it sounds like the symptoms that a lot of our patients have is not just their body, quote unquote, falling apart, that there's actually names and phrases that we can put to these, and there's actually treatments that we can use to get people feeling better if they present these symptoms, talk about these symptoms to their gastroenterologist. So what about you, Dr. Wells? What are some of the joint and back symptoms that some of our IBD patients should watch out for? And how do you treat those?
Dr. Iroku, that's a very good question. Rheumatologists treat diseases of the muscle, bones, and joints, but we also treat another group of diseases, what we call the connective tissue diseases. So the connective tissue are things that connect the body together. It could be the eye, it could be the bowel, it could be the skin and the kidneys. And we have some amazing drugs that target our diseases. When you see somebody who has active inflammatory bowel disease, they can develop joint inflammation as well. And that's represented by painful swelling of the hips, knees, and ankles. But it also can involve the small joints, involving the knuckles, the wrists, and other parts of the hands. And the amazing thing is we have some great therapies that you use to treat these patients. And which therapy I choose depends on what other comorbid condition that we're treating with the patient. So if somebody has bowel disease, arthritis, and eye disease, I'm going to pick a medication that's going to cover all three of those. I have pills, I have injections, I have IV medications, and all of those help our patients. One other thing I'll highlight is with our juvenile patients. I see a lot of kids under the age of 18 who present with inflammatory bowel disease and arthritis. And many people have overlooked the arthritis. They don't appreciate the joint symptoms that young kids are having. So I make a joke, for kids, they don't invent stuff. If they have pain, you believe them. If my kids say there are ghosts in the house, I'm moving. So kids don't really make up things. So really believe those kids. And so at the end of the day, with a rheumatologist, we're looking for painful swelling of the joints, for other symptoms involving the eyes and other organs of the bodies that we can link together that might be a sign of inflammation.
I love it. And so what about you, Tamar? What are some of the nutritional deficiencies that may occur in my IBD patients? What are some general symptoms that they themselves might feel? And then lastly, is there a silver bullet recipe that can address all of these issues at once?
Yeah, great question. Actually, about 85% of people with newly diagnosed IBD have malnutrition. So we know that malnutrition is a huge concern, especially for individuals who are just diagnosed and haven't been treated. Some of the most common nutrient deficiencies that we see are iron, especially during periods of active GI bleeding. And some common symptoms of iron deficiency include very low energy and fatigue, especially when exercising, difficulty breathing, and even impaired cognition. But really the most classic sign of iron deficiency is fatigue. So if you're getting good rest and you still feel exhausted all of the time, then that is a big sign that you might be iron deficient. A lot of patients with IBD also have unexplained weight loss. So this is a big one. If you are actively losing weight without trying, that's a sign that you are malnourished, that you're not absorbing nutrients. People with IBD tend to need a little bit more protein than the average individual. So really important if you're losing weight, to make sure that you're speaking with your doctor to get a diagnosis or a workup. Other nutrients that we want to be mindful of are vitamin B6 and vitamin B12, particularly for individuals who have Crohn's disease, because we know that it affects the small intestine and we're more likely to be nutrient deficient with that condition. Other things to be mindful are calcium deficiency and vitamin D deficiency. Some signs and symptoms of deficiencies in these nutrients are bone fractures, weak nails, hair loss, again, fatigue, and even depression. And then zinc deficiency is really common in people who have chronic diarrhea, which we know a lot of our IBD patients do. And some clear signs and symptoms of zinc deficiency include altered sense of taste and smell, poor wound healing, hair loss, and even difficulty seeing at night. Also, interestingly, which is something that I think a lot of people don't talk enough about, is eating disorders are very common within the IBD population. Oftentimes people will self-treat. They know that food, and every time they eat, it causes GI symptoms. And that causes a lot of fear around food. And so that can translate into more severe eating disorders. related to really just trying to manage their gut health. So those are some signs to look out for in terms of malnutrition. And when it comes to that silver bullet, we all want a silver bullet, don't we? It would be so nice if we could just take something and it would solve all of our problems. But unfortunately, when it comes to nutrition and most health conditions, there is no one thing that we can do to address these issues. We really have to approach it from a personalized perspective. Not everyone who has IBD has these nutrient deficiencies. So it's really important to work with your doctor and your dietitian, collect as much data as you can, and create a full picture of what might be going on so we can treat from a nutrition perspective more intentionally and focus on certain foods that we know are important to help manage these deficiencies or gain weight.
Love it. I love it. So it sounds like you're saying that magic probiotic that's the nice people online are offering me for $29.99 is not going to be the solution. That's good to know. And on that point, we're going to go into a section where we're going to start busting some myths. It's time to set some of the records straight on a lot of the comments that I hear and questions I hear from my patients, especially from the Black community. All right, so Dr. Turner, you're up next. A common statement I often hear from my Black patients is that skin cancer is not a Black disease. Black people don't get skin cancer. They don't have to worry about it. We don't need to wear SPF 30, 45, or anything. You don't have to cover your skin. And they definitely don't need to see a dermatologist out of any fear for having skin cancer. Can you speak to that and the need for routine skin exams in the immunosuppressed patient?
Absolutely. This is something I hear commonly from the most melanated patients. And I think a lot of this myth comes from education not being there in childhood, because the darkest skin tones don't tend to burn. There is an education in sun protection and sun avoidance. And then culturally, we also hear that skin cancer just simply doesn't exist in Black skin. So these two items tend to keep reinforcing that, and it makes it on into adulthood. So there will need to be some myth busting here in terms of things, because very much skin cancer is a real thing in all skin types. So in immune suppressed patients, it's important that routine skin exams be done, because simply by being immune suppressed, this is going to open us up for our immune system not being able to survey the skin as it normally would, and things are going to escape that immune surveillance and then become skin cancers. We do know that with certain skin cancers, they can be related to different immunosuppressants, and risk can be increased for things called non-melanoma skin cancers, which are things like basal cell and squamous cell. And certain medications can also increase risk for melanomas.
Excellent, excellent. That's great. All right, Dr. Wells, another common myth I often hear is when it comes to medications, avoid them. Avoid the medications as long as possible. Do natural sources, fix your diet, but don't get on medications for as long as possible when it comes to rheumatological illnesses. Is that true? Should your medications be avoided? Are your medications worth taking?
Absolutely. And I tell people, first of all, some patients, when they see the TV commercials, say, oh my gosh, the side effects of the medication sounds worse than my disease. But I say, hey, that's what you're paying me for. All medications have side effects. I tell people, if you take too much calcium, you can get kidney stones. As a GI doctor, you know, if some patients take too much vitamin A, they can get liver cirrhosis. So indeed, if I talk about an advanced therapy, a biologic drug, a topical, or an oral drug, then yes, we can see some side effects for those. But guess what? That's why you have me. I routinely see my patient every 3 to 4 months. We do video visits. They can text me. They can send these messages through Epic if they have side effects and questions and concerns. And indeed, many patients, you find out if you treat them aggressively earlier on, then you're able to decrease their therapy. Let's say if I have a patient on an injection I do twice a month, if I treat that patient aggressively up front, treat them twice a month for a month or two, then go down to once a month, and then once every other month. So just like what Dr. Turner mentioned, we have our patients to get a skin exam every year. they definitely need some blood work, and they need to see me as well to making sure that that lesion on their palms, that dot on the back is not going to be a melanoma or another what we call a non-melanoma skin cancer as well. So at the end of the day, vitamins, everything, and many things people are taking over the counter, think they're safe, have side effects. I said, that's what you pay me for. Let me do my job and let me treat you. And the way I help my patient to talk them through this conversation, I said, what would I do if you're someone in my family? And indeed, if you're my mother, my wife, or somebody in my family, I want the best care, but I also want to be the best surveillance and making sure that you don't have side effects from medications, or as few as possible.
I love that. I love that. There's a term that we gastroenterologists love stealing from you rheumatologists, and that's the term disease modifying. And the idea is that there's some medications that you use that aren't just placebo, they aren't just band-aids, they're actually changing the nature of the years to come that a person will have with that disease. And that if they take those medications up front, they're going to have a better life with less symptoms, or be more likely to have a better life with less symptoms than if they wait to the last moment where their joints are scarred and they're having deformities. And that bringing those medications on earlier is actually the way to go.
And I totally agree. And that's one issue we have when we deal with disparities, with some of our patients of color, poor patients as well, not just people of color. I say, some doctors, wait to treat them until the cat's already out of the bag. So if you treat them earlier on, guess what? You can end up saving more money and therefore increase the quality of life that many of these patients have.
Exactly. You deserve excellent care. All right, Tamar, what about you? Another myth that I've heard is that, again, if you go online, that IBD can be cured with diet choices only, and that you feel bad because you ate bad. How do you approach this myth or this question?
Yeah, such a good question. We know that nutrition and the food that we eat is fundamental to our health overall. So there's no doubt and there's no arguing that nutrition is really important for preventing and helping us to manage IBD. That said, nutrition alone is often not enough, the majority of the time, not enough to manage these conditions. And as I mentioned earlier, a lot of the protocols that are out there in terms of diet for IBD are incredibly restrictive. These protocols are cutting out entire food groups, and they're really not meant to be followed in the long term. And when they are followed in the long term, that could lead to things like eating disorders, nutrient deficiencies. And so it's really important to make sure that you're working with a multidisciplinary team when it comes to treating IBD. There's a lot that we can do, and there's definitely some good research on studies that have shown that foods like high sugar diets, highly processed foods, diets that are high in omega-6 and low in omega-3 may be associated with an increased risk of IBD. But when it comes to nutrition and treating IBD, it's always important to work with all of your providers and really look at it very holistically to get the best outcomes. And again, speaking about quality of life, having these really restrictive diets that don't have a lot of research, don't have a lot of evidence behind them, may or may not be effective, really has a negative impact on our quality of life. So really important to use a combination of different tools and resources to get better outcomes.
If you are joining us, welcome yet again to Inside Tract from ABGH, the Association of Black Gastroenterologists and Hepatologists. Again, my name is Dr. Ugo Iroku, your host for the evening, and I am thrilled again to have our amazing panel, Tamar Samuels from Kalina Health, Dr. Alvin Wells from Aurora Healthcare, and Dr. Ryan Turner from Turner Dermatology. They're answering your questions as we talk about navigating your IBD care with a team approach. Tamar, I have another question for you. What about the high fiber diet? Oftentimes I have patients they're looking online and they're trying to figure out, again, how best to approach their gut health. And they often hear from gastroenterologists or their primary care doctors that a high fiber diet is a very gut healthy diet. And then other times they see that a high fiber diet is not the way to go with IBD. So what's the answer? Is a high fiber diet ideal for an IBD patient? Yes or no?
Well, unfortunately, yes or no is a little bit polarized. It's hard to answer yes or no when it comes to anything as it relates to nutrition. Interestingly, studies have found that high fiber diets are actually associated with decreased inflammation in patients who have ulcerative colitis. At the same time, we also know that high fiber diets may be associated with an increased risk of flares in some patients. So when it comes to ulcerative colitis and Crohn's disease, it really depends on the type of fiber and also on individual tolerance. So really important to approach this from a personalized perspective. Generally speaking, there are two different types of fiber. So I like to really get into the nitty-gritty of what fiber is when I speak with patients about fiber and IBD. Soluble fiber is a gel-like substance that draws water into the colon and it slows down digestive transit time. It can be helpful for both constipation and diarrhea. And then we have insoluble fiber, which adds bulk to stools. It passes through the digestive tract more quickly than soluble fiber. Generally speaking, insoluble fiber can be found in foods like vegetable skins, stems, roughage, and seeds. And so we want to shift the proportion of fiber more towards soluble fiber, which also really helps to support gut health. But we want to be really careful about how much fiber we're using. And when we're having a flare, we want to decrease fiber intake. So when we're not having an active flare, we want to gradually increase fiber to your tolerance. And people with IBD can also have insoluble fiber, but we can modify textures to make sure that they're better tolerated. So having smoothies, pureed or cooked soups, having well-cooked vegetables, peeling fruits and vegetables, having smooth nut butters instead of chunky nut butters, and even just chewing really well, eating really slowly and mindfully. All of these techniques can help you to tolerate fiber better, but want to be really mindful about personal tolerance and really go slow. So experiment with one high fiber food at a time. So unfortunately, I can't say fiber diets are yes or no. It really just depends on the individual and where they're at in terms of symptoms.
I love it. I love it. All right. So Dr. Wells, I have a question for you. Oftentimes, we see IBD patients in our gastroenterology clinics, and sometimes their gut symptoms are doing great, but at the same time, they're having joint pain or they're having back pain. Or vice versa. Sometimes their joint symptoms are great, but they're having diarrhea. There may be blood in the stool. They may have frequent bowel movements. How do you recommend a patient address this issue when one part of their IBD is manifesting in a great way, but the other part, maybe the extraintestinal manifestation, is not doing so well? How can the patient address this? And then what can the docs do to help out?
Yes, I think the first thing, like we said earlier, that you should know your body better than anybody else. And then indeed, if you have these issues, you need to reach out to your provider. One thing I talked to about Dr. Iroku, first of all, it could just be fatigue. Patient with bowel disease and arthritis, they can go to bed at night and they wake up, they're in bed 7-8 hours, and they feel like they've been hit by a truck. And the fatigue could be one of the first signals that, hey, now the inflammation is beginning to ramp up, and then we need to indeed address those things. The amazing thing now with all of our different targets, by pills, by injections, and IV medications, I can come up with a regimen that's going to target the eye and the bowels, the joints and the bowels. And if you're having an activity in one area of the body versus another, we can indeed target that. It might be topical for skin stuff like Dr. Turner alluded to. It might be other injections. If it's just one or two joints, we might do a joint injection to get that patient under control. So at the end of the day, knowing your body, and don't be afraid to reach out to your provider if you have new symptoms that is not unexplained, because we can help you put that in perspective in regards to your overall disease and your disease activity.
That's excellent. All right, Dr. Turner, I have a question for you. Very simply, what are melanomas and how do they present differently in Black patients? How do you treat them?
Yeah, this is an excellent question and one near to me because I diagnosed my own skin cancer a couple of years ago. There are different types of cells that are within the skin. So melanoma, for example, is a skin cancer of the melanocytes, which give pigment to our skin. And then we have non-melanoma type skin cancers. And these are common skin cancers like basal cell or squamous cell, and potentially could be more rare types of skin cancers like sebaceous carcinoma or Merkel cell carcinoma. And these can present differently and in different locations, especially in patients who have more melanin in their skin. So, for example, melanomas in darker skin types are typically found on acral lesions, meaning on hands or feet. This is another myth in terms of the Black community, that skin cancers don't happen in melanated skin. And it's not only related to sun, there's certainly a genetic component to it. So I encourage my patients once a month to take a look at their hands and feet, paying particular attention to their nails, and if there are any what we call longitudinal melanonychia, are there lines or streaks in the nails. I educate patients on looking for bumps or dark bumps right at the cuticle area. And then sometimes they can actually be without pigment and have an amelanotic melanoma. And this can look like a red dot underneath of the nail, and or it could also present as a red streak in the nail. In addition, in more melanated skin, non-melanoma skin cancers such as a basal cell will often have pigment. So a lot of times a patient with darker skin will present and say they have a quote new mole, but on higher magnification, it can be quite obvious that the patient has a basal cell, which in more fair skin looks like a translucent or can be a red obvious dot on the skin. For melanoma type skin cancers in darker skin patients, these are often delayed diagnosis or misdiagnosis. So it can increase the mortality in African American or Black patients. Treatment of melanomas is surgical. Typically by wide local excision. Nowadays, Mohs micrographic surgery can be used for thin melanomas of the face, which is a type of skin cancer procedure which spares the amount of skin taken. So this is very useful for areas on the face, for example, like the eyelids. In addition, we have a lot of advanced therapeutics now for melanoma that are quite effective in treating metastatic disease. So that has been a very exciting addition to treatment in melanoma in these last years. Non-melanoma skin cancers like basal cells and squamous cells are also treated by wide local excision in a lot of cases, or non-melanoma skin cancers found on the head and neck are oftentimes treated by Mohs micrographic surgery. Again, that's a tissue sparing technique such that the most small amount of skin tissue can be taken and not have any functional impairment to areas such as the eyelid or the lip.
That's wonderful. And so I could talk to you all night. You all have really been excellent, I think, about showcasing the depth, passion, and expertise of the multi-specialty care that our IBD patients deserve. And so I really give, a clap and congratulations to all of you just for what you've done and achieved, and for communicating that to our patients tonight. And so I'd like to give you all a final word. Our patients are interested in hearing what you're doing. How can they connect? And I'll start with you, Dr. Turner. If one of our patients is interested in learning more about what you're doing, what Turner Dermatology is up to, what all the buzz is about, how can they find out more about you, either online or on social media?
Yeah, absolutely. On social media, I have a very simple handle at Dr. Ryan Turner. So I have an active Instagram page there. You can also find my practice in New York City at turnerdermatology.com. So that's also very easy to access me, give a call to the office, book an online appointment. And you can also find me teaching at Montefiore Hospital once a month, where I'm also seeing surgical patients.
Right. And Dr. Alvin Wells, what about you? If someone's interested in your education on social media or what you're doing in Aurora Healthcare, how can they connect with you?
Yes, and one of the nice things about my role, I'm the Midwest Region Director, so I cover 2 states, Illinois, Wisconsin, but I have a license in 5 different states, South Dakota, Montana, Illinois, Wisconsin, and North Carolina. And so I know there's a shortage of rheumatologists, but there's no shortage of the internet. and patients could connect with a rheumatologist, whether that's me or someone else, to making sure you get the workup, getting the treatment, and making sure you're getting recommendations for these advanced therapies. If you look at my name, I have a YouTube channel. I have them on LinkedIn and what used to be called Twitter and Instagram as well. And I think Ms. Samuels will appreciate on my Instagram, I'm not doing any videos or songs. I'm posting healthy recipes and workouts and things like we're doing to kind of making sure our patients live healthy as well. At the end of the day, you know, don't say no. Don't take the answer no from your other clinicians or providers. If you think you have symptoms, reach out to someone. And in this virtual world, you have experts like on the line tonight that can help you point you in the right direction.
Excellent, excellent. And what about you, Tamar? How can people connect with you and the amazing work that Kalina Health is doing in the community?
Yeah, so at Kalina Health, our mission is really to make nutrition accessible and sustainable for everyone. And so as a company, we take insurance, which I think is so important. Most registered dietitians don't take insurance. We also have the most diverse registered dietitian team in the entire country. Our dietitians speak different languages, and we always honor cultural foods with all of our patients. We have ongoing training in cultural humility and cultural competency, and we make it really easy for you to book a session with us. So all you have to do is go to our website, kalinahealth.com, and click the button to get started. We will collect your insurance information, confirm your benefits before you get into care. And our care is 100% virtual, so you can meet with your dietitian from your phone. We'll be at our desks, but you can be in your car if you need to be. And you can also find us on Instagram. We have a ton of great content, lots of recipes, lots of fitness tips, stress management tips. And then on our blog, we actually have some great articles about IBD and free resources as well.
Excellent, excellent. So once again, on behalf of our IBD community, we'd like to thank our amazing panel. And for those of you who are new to ABGH, the Association of Black Gastroenterologists and Hepatologists, you can follow us on X, formerly known as Twitter, and IG at Black and Gastro. And of course, you can check us online at blackandgastro.org. Thank you for joining us for today's installment of Inside Tract. Good night.